In this podcast episode, Dr. Antonio Bianco, a leading expert and dean of a prominent medical school, unpacks the biology, physiology, and clinical challenges surrounding thyroid hormones. With decades of research and patient experience, he sheds light on why traditional approaches may not be enough and how new strategies are poised to transform care. At the heart of thyroid function lies a finely tuned biochemical system that begins with the thyroid gland trapping iodine from the bloodstream to synthesize thyroid hormones. Most people hear about T4 and T3, but few grasp the sophistication behind these molecules. The thyroid primarily produces inactive T4, which surprisingly holds 4 iodine atoms. Through smart evolutionary design, T4 serves as a storage and transport molecule, letting the body selectively activate thyroid hormone by removing a single iodine atom to create the biologically active 3. This dynamic is more than molecular trivia. It ensures efficient iodine conservation in a resource-limited environment, enabling tissues to regulate their own exposure to active hormone as needed. This process is exquisitely controlled by enzymes called deiodinases, which determine whether T4 converts to active T3 or to an inactive form called reversed 3. This balance between activation and inactivation allows the body to finely modulate energy expenditure and metabolic activity. The half-lives of these hormones starkly contrast. T4 lingers for about 8 days, while T3 acts sharply but transiently within 12 hours. How does this interplay influence organ function? Research shows that in tissues like brown fat and the brain, local conversion of T4 to T3 can spike dramatically without reflecting in blood levels, implying that blood tests alone may miss critical tissue-level dynamics. If the biology is this complex, how do routine laboratory tests capture thyroid function? The standard panel often includes TSH, free T4, and sometimes total T3, but as Dr. Bianco explains, these tests primarily rely on immunoassays that vary in accuracy, especially for T3 and reverse 3. Crucially, the majority of thyroid hormones in blood are bound to proteins and inactive. Only the tiny fraction free and unbound truly accesses tissues to enact biological effects. This makes measuring free hormone levels imperative, but challenges persist as existing assays for free T3 and reverse T3 lack precision. The TSH test is a centerpiece because it reflects pituitary feedback to circulating thyroid hormone, but its interpretation is far from straightforward. Consider phenomena like fasting or illness, where TSH may appear deceptively normal even as active hormone levels plummet systemically. Additionally, interference in assays, such as antibodies disrupting the measurement, can mislead diagnoses. Is it possible that many confusing cases arise from such interferences? Dr. Bianco advocates for improved testing techniques, particularly mass spectrometry-based assays, to accurately quantify T3, as a critical advance for better diagnosis and management. One of the most fascinating revelations is the role of the 3 distinct deiodinase enzymes, D1, D2, and D3, in regulating thyroid hormone activity at a local level. D2 acts as the main converter producing T3 outside the thyroid, with remarkable affinity, especially in the brain and pituitary, enabling local regulation of feedback mechanisms. D3, conversely, serves as the inactivator, transforming active T3 into inactive metabolites, effectively acting as a brake on thyroid hormone action. The balance of these enzymes shapes tissue-specific thyroid hormone levels independently of the blood's hormone concentration. This decentralization challenges the assumption that measuring circulating T4 and T3 alone suffices. Could this enzymatic regulation explain why some patients with normal blood tests still experience hypothyroid symptoms? By altering local activation or inactivation, the body can fine-tune hormone effects dramatically, necessitating more nuanced clinical approaches. Central to thyroid regulation is the Hypothalamus-Pituitary-Thyroid (HPT) axis, a precise hormonal cascade whereby the hypothalamus releases TRH, thyrotropin-releasing hormone, to stimulate the pituitary gland's secretion of TSH, which in turn drives the thyroid gland's production of T4 and T3. Interestingly, parts of the hypothalamus are not shielded by the blood-brain barrier, allowing these brain regions to directly sense circulating thyroid hormones. This anatomical feature empowers real-time hormonal feedback, crucial for maintaining homeostasis. However, Disorders disrupting this axis, like central hypothyroidism resulting from pituitary or hypothalamic dysfunction, pose unique diagnostic challenges. In such cases, TSH may be inappropriately normal or low despite low thyroid hormone levels, or vice versa, obscuring the diagnosis. Understanding the axis's nuances safeguards against misinterpretation of lab values and mismanagement. Although hypothyroidism dominates in prevalence, hyperthyroidism has distinct presentations and etiologies demanding attention. Graves' disease, an autoimmune condition where stimulatory antibodies mimic TSH, causes diffuse thyroid hyperactivity. Patients often manifest palpitations, weight loss, heat intolerance, and tremors, signs of metabolic overdrive. Treatment options include anti-thyroid drugs, radioactive iodine ablation, or surgical removal, each with pros and cons. Historically, radioactive iodine was common in the U.S., but emerging data suggest potential increased risks of certain cancers, prompting some practitioners to favor medical therapy or skilled surgery. The decision-making balance here involves patient age, disease severity, and risks. Additionally, hyperfunctioning nodules present another hyperthyroid etiology, generally resistant to remission, often necessitating surgery. Hypothyroidism, characterized by insufficient thyroid hormone production, manifests subtly or severely, with symptoms often nonspecific: fatigue, brain fog, weight gain, and mood disturbances. Most commonly caused by autoimmune Hashimoto's thyroiditis, where antibodies assault the thyroid gland. The disease progresses from antibody positivity and elevated TSH to frank hormone deficiency. Diagnostically, elevated TSH coupled with low free T4 confirms the diagnosis, but early honeymoon phases or subclinical disease, where TSH is raised but hormones remain normal, complicate interpretation. Antibodies are helpful markers, but can be absent in a significant minority of hypothyroid patients. Interestingly, antibody positivity, even in euthyroid individuals, correlates with adverse pregnancy outcomes, highlighting the thyroid's systemic impact beyond hormone levels alone. Thyroid hormone replacement remains largely anchored by levothyroxine, synthetic T4, favored for its long half-life, ease of dosing, and stable pharmacokinetics. Paradoxically, despite decades of widespread use, levothyroxine was approved without rigorous clinical trials and does not fully restore normal tissue thyroid status in all patients. Many individuals continue to experience residual symptoms or metabolic abnormalities like dyslipidemia, implying incomplete tissue-level euthyroidism. Adding T3, either as liothyronine, synthetic T3, or via desiccated thyroid extract from animal glands containing both hormones, has rekindled debate. While T3's short half-life complicates dosing and raises concerns about blood level fluctuations, some clinical data suggest combination therapy reduces mortality risk more than levothyroxine alone. Yet the absence of compelling, large-scale randomized trials leaves controversy unresolved. Could a slow-release T3 formulation, currently under development, transform therapy by mimicking physiological hormone delivery? Patients frequently present with symptoms suggesting hypothyroidism, yet their laboratory tests remain normal. Here, the distinction between clinical and biochemical hypothyroidism sharpens. Symptoms like fatigue, weight gain, or low body temperature are nonspecific and overlap with conditions such as menopause, anemia, or psychiatric disorders. Objective lab values, especially elevated TSH and low free T4, remain the cornerstone of diagnosis. Dr. Bianco underscores that T3 measurement has limited diagnostic utility for hypothyroidism due to compensatory upregulation of peripheral conversion to maintain T3 levels. Secondary hypothyroidism, stemming from central gland failures, is rare but identifiable by inappropriately normal or low TSH alongside low free T4. Such nuances demand clinician vigilance. Should one rely on temperature charts or subjective feelings alone when biochemistries tell a different story? Hashimoto's hypothyroidism displays a striking gender skew, affecting women roughly 10 times more than men. The precise reasons remain elusive, though hormonal influences and subtle differences in thyroid antigenicity are suspected. Age further modulates thyroid parameters. Older individuals naturally trend toward higher TSH reference ranges, prompting adjusted diagnostic thresholds. For example, a TSH value of 7 in an octogenarian may be normal, whereas in younger adults, it warrants close evaluation. Pregnancy uniquely stresses the thyroid axis, with autoimmune markers impacting fetal outcomes even if hormone levels appear normal. Postpartum thyroiditis exemplifies this challenge, where transient or permanent thyroid dysfunction can occur. These biological variables complicate standardization in diagnosis and treatment, advocating for personalized medicine approaches. Perhaps the most potent takeaway is the urgent need for advancement. The thyroid field awaits wider adoption of mass spectrometry-based assays to accurately quantify free T3 and reverse T3, essential to understanding patient-specific hormone dynamics. Equally critical is the development of slow-release synthetic T3 formulations to mimic natural hormone secretion, overcoming the drawbacks of current immediate-release T3 therapies. Dr. Bianco's vision extends beyond biochemical normalization. He advocates holistic care, recognizing hypothyroidism as a risk factor for cardiometabolic disease rather than a mere lab value irregularity. Would we settle for treating only numbers if patients still suffer? The call to action is clear. Better science, improved therapeutics, and patient-centered care must coalesce to transform outcomes.